All right, Finance Committee will please come to order. Welcome, everybody, and good morning. Any citizens in the audience wishing to address the board? All right, we'll move on to item 3, approval of the minutes. I'll entertain a motion for approval of the December 17, 2017 minutes. Motion by Dr. Weber, second by Mr. Bose. All in favor, please say aye. Opposed, motion passes. Thank you. Item 4, CFO report. Ms. Clark. Good morning.
How are you? I do have some good news in my November and December reports. I just have 2 matters to update you on. In your board portal under the library, we do have 3 final audit reports from BKD for your reference. As you recall, last time we met, Chris Clark reported to you the draft final audit report for JPS. It is now in its final form on your board portal, along with the final audit report for the foundation and the single audit, which used to be the A133 for our federal and state awards. So those are there. If you have any questions, feel free to contact me with those. And we also just received and posted the 12/31 quarter-ended investment report from First Southwest. Again, we will post those quarterly for your review. And if you have any questions, please let me know on that one. And that is all I had for my report.
Okay.
Yes.
Any questions for Sharon? All right, you want to move into item 5A, or November audit financials?
Okay, so for our second month of this fiscal year, we have pretty strong volumes. For the admissions, we were about 8% over our budget. And you can see towards the bottom of the page, our case mix index was also strong at about 2% above budget. And our length of stay corresponded with that, acuity with about 3% ahead of budget. Our emergency department was also busy. We were right on target with budget for November. And our clinic visits were also right on budget. Urgent care was about 2% under. And our total outpatients, which is a huge conglomeration of a lot of different factors, was just slightly, just about 0.5 percentage point below budget. From a different viewpoint, our observation cases, which are those that don't really qualify to be an inpatient stay, but are in an inpatient setting, those were 11% higher than budget. Our invasive lab cases were right on budget. We were within 1 case of hitting our budget, even though it's showing yellow on our graph there. Our inpatient surgeries were under budget this month by about 17%, but our outpatient surgeries were right on budget. And from a psych standpoint, our inpatient psych days were about 4% over. The clinic visits were 19% under. And I will tell you, if you look at the graph, we did some pretty aggressive budgeting for this year, and you're going to see that those will probably remain under budget for at least the first part of the year. We had expected some additional providers and some changes to occur that have not yet happened, but we are equal to the prior year. You can see by the yellow and the blue bar. So we did not hit the budget, but we are equal to about where we have been in the prior month and equal to last year. The ED, the psych ED, is slightly under budget as well, but equal to the prior year. And our PHP is about 8% under. And then if you look at some of our rev cycle metrics, days cash on hand is at 159. I'll tell you for December it had increased a little bit, and we'll go over that in just a second. But again, you know, looking at prior year, October, November, December is always our low quarter. We'll be getting our big cash payment for property taxes in January and February, so you'll see that go up this month and next month when I report out for January and February. Our days receivable is 51. And then at the bottom of the page, you'll see our FTEs per adjusted patient day. Our overall year-end goal is the 5.8, and the 2 months in, we're at 5.71. So that the way that we're flexing our staff for the first 2 months is favorable to that overall target. I covered those fairly quickly. We do have 2 months to cover for November and December. Do y'all have any questions about those statistics before I get into the financial numbers? There's our payer mix slide. We don't have any major changes. And you'll notice our connection enrollment slide. We're up to 41,459 enrollees. That continues to creep up. We did have about 1.5% increase in our enrollment this month.
The key will be how the January numbers look.
Yes, Steve raises a good point. We have two main components within the connection program. We have the traditional connection and program enrollees, which is the largest portion. And then we also have the Connection Supplemental Program, which is administered through our foundation. And those are enrollees who qualify that have enrolled in some of the higher ACA plans that are receiving their services at JPS that we can help facilitate. As some of you are aware, the ACA plans have a massive enrollment and re-enrollment in January. And if those participants do not re-enroll, then we, as you can see in the graph, in January, we have a dip in the overall connection enrollment because of that. And then as we get new enrollees signed up, we see that slow uptick. So hopefully we're not expecting a huge decline in January, but we'll be watching that. So, any questions?
So do we reach out to those particular persons prior to that time to see about trying to keep them under the plan, or?
We do. We don't administer those ACA plans, but we do try, we send a lot of communication out, and we also try to contact those people as best we can. So we have a lot of efforts going on through the eligibility office in both November and December to try to prevent some of that downtick. A lot of it also has to do with their eligibility to be in those plans as well. Because you just have to qualify at the time of enrollment, and then you are in those plans for 12 months. So you have to qualify to also re-enroll. So for the month of November, we had a very strong net patient service revenue. As you can see, we were 1.2 million ahead of our budget, and a lot of that had to do with those strong admissions that we saw at the beginning of my presentation. Admissions, again, were 8% up, but in conjunction with that, we also had a very strong payer mix. So, some months we have favorable payer mix, some months we do not. We have more commercial patients, and November was one of those months that we can see a favorable impact. In the operating expenses, you can see that we also had a salary overage. Most of that, again, was to pay for the staffing for those volumes. If you look at just the FTE per APD for the month, we were at 5.81 compared to a budget of 5.88. So again, for the month, that staffing was favorable. The graph that I went over prior was the year-to-date for the 2 months compared to our annual target of 5.8. Down in the expense categories in purchase service, you'll see a slight overage of $903,000. I'm going to take a few minutes to explain this because you're likely going to see an overage in this for most of the remainder of the year. If you remember, we had part of our program through the Tarrant County Instrument Care Corporation, TCICC, where we offloaded physician contracts, which gave us the ability to IGT for other Tarrant County facilities that were not governmental facilities that could IGT for themselves. So TCICC dissolved for many different reasons, and beginning in October, we began to pay those contracts ourselves, those physician payments ourselves again. And it's a complex arrangement. But the budget impact on that line item of us paying is about a 10 or 15% increase in expense than the offload. So you're going to see a slight overage each month in our purchase service due to those physician contracts. So that is the main reason for that overage. The next line item for the supplies, you'll see an underage of 1.2 million. That has three main components. We are under budget in some lab that we are still outsourcing, so we are not incurring those reagents that were budgeted. We are also under budget in some pharmaceuticals and some other medical supplies, mainly due in the medical supply category to some of the underages in the surgeries that we went over earlier.
Sure.
Yes, ma'am.
On the purchase service one where you said we're going to continue the hit, now help me understand that big increase. We were already paying the contract for the physicians. We were just giving it to someone else, to the whatever.
Yes, ma'am.
And then they were paying the doctors. So what is the increase? Why is such a large increase?
So part of the complexities of the offloaded contract is that it also impacted some of the levels that we get paid for our dish cap. So when we offloaded those contracts, they paid the full contracted amount, and we IGT'd about 90% of those expenses, and we lost some cap room for dish. So overall, it came out of some different categories.
Sharon, where are we sending IGT if there's no TCICC anymore?
That's what the LPPF arrangement has started to do on their behalf.
Okay.
And that is not reflected on the income statement. for us anymore. Although we administer that program and you guys approved to be able to gather those funds, we still administer that IGT. It's just not an offload arrangement that's required to be on our income statement.
So do the other hospitals that were participating in TCICC now access that same mechanism for UC?
They do.
Okay.
Yes. So the bottom line, at least the income from operations, the medical center had a $474,000 operating margin compared to a $565,000 budget for the month. Year to date, we are at $49,000 compared to $1 million budget. And we'll continue on the discussion in December when I get to the following month. Are there any questions for November? Okay. For Acclaim, Acclaim's billed encounters were down by about 3%. We still are filling positions in Acclaim. And I also wanted to point out the bottom right graph, which is the net operating expense per encounter. Year to date, we do have a favorable expense per encounter, and it is favorable by almost 6%. So it's costing us a little bit less to provide services based on volume. So when you look at the Acclaim performance for November, kind of jumping down to the bottom line, from income from operations, they were at $1,017,000 compared to $1,005,000 budgeted operating loss. So they were favorable to budget by over $500,000 for the month. There were several items that helped create that favorable variance. You know, if you start at the top half, they were under budget in their total net patient service revenue, but that was also offset by some underages in those open positions for salaries and benefits, as you can see. And they also had some underages in some purchase services with some provider fees, about $174,000 worth of savings there, and some underages, smaller underages in other operating expenses. But when we look at December, some of those timing issues kind of were offset in December. Are there any questions for November before I get into December? Okay. So admissions in December was up by about 4%. Our case mix was also up by 3 percentage points. And our length of stay was unfavorable by 7%, mainly driven by that acuity. Emergency department shows to be about 2% behind our budget, but I do want to point out it was up from last month, and it was about 3 percentage points up from prior year. So it could have just been a slightly aggressive budget. Looking at urgent care, it does follow the same trend, although we were about 2% behind our budget. It was up 4% from last month and 9% up from prior year, as you can see by that blue bar. Our total clinic visits were down 8%. However, we were up 1% from prior year. And when we get to Acclaim, we'll see that there were a lot of providers that did take off for the holidays, and that may have been what was driving some of our our downward trend in some of the clinic visits. In other key stats, our observation visits continued to be up by about 4%. Invasive labs are down by 8%. And both our inpatient and outpatient surgeries were down 17 and 10% respectively. Our psych looks a lot like it did back in November. We were about 3% over on our inpatient days. The clinic visits, it continues to be an aggressive budget. We were down by about 25% there. Our psych ED is down by 11%, but equal to the prior year, if you look at the graph. And our PHP is down by about 18%. Yes.
The reason we're seeing the decrease in all the psych is how we target our visits?
No, the information or the conversation I was having about the way we budgeted was specific to the clinic visits, so just the top right graph. The psych ED is really, most of that is unplanned. So that is the ED that is really just driven by the walk-in traffic. So I'm not able to speak to, what's driving the volume there. That is more, I believe that's on the 10th floor. And that is more just the unplanned. That is not the visits themselves. That's not scheduled. So as you can see, if you look at the kind of the beige bar from prior year, you remember that we had kind of a quarter that spiked that we could not explain last year that created kind of an overwhelming volume there. And if you look at today's blue bar, it's really comparable to the prior 2 years from volume. So I think what we tried to do, if you look at the red line from a budgetary standpoint, right or wrong, is we looked to see what had happened, kind of the way that the volume had trended towards the end of the year, and tried to smooth that out. But what's happened is we fell back to November, December volumes of prior year. It did not continue at July, August, September volume. So, yes. We still have some open positions in Acclaim, and we can look, and a lot of the open positions that we have in Acclaim, a lot of the underages and the visits are in primary care.
That was probably because of staffing issues.
Mm-hmm.
We don't have, or could that be because,
Are you talking about the clinic visits?
or sometimes when you have more severe cases, delays in receiving that patient? So I'm not sure.
So again, with the clinic visits on the top right, when I looked at that in December, we were right on target, actually a little bit ahead of where we were this time last year. And again, when we budget, we have to try to take into account a lot of different factors from an average standpoint, where we think we're going to be with hiring, and we don't really know what behavior from a scheduling standpoint is going to be. So it could have been driven by our patients. It could have been driven by physician availability. I did not get all of that information before today.
Because what I'm trying to get my hands around is that because we have a big push with this rep for access,
Yes.
and when I see those numbers down, is that because of the district coming down and we don't have caseworker or something. I don't know what I'm looking at. So I'm just trying to get some fill in the blank there.
What I can do, DT, is we can dig into that a little bit. So if you look at October numbers, I have those specific numbers in front of me. When you look at the blue bar, we were able to see 53,788 visits in October, 49,817 visits in November, and the visits fell to 45,062 in December. So the clinicians, the clinics themselves were able to accommodate in October a much higher volume. So to me, that's sounding more like it's just a fluctuation that's happening. But we can drill down through that and perhaps bring a more detailed presentation back.
I have one other question on our surgery. It looks like every month we are moving down. Is that due to staffing or?
So I can speak a little bit to surgery. I know that we, for the last few months, have been going through a transition time in surgery. And when I get to the Acclaim part of the presentation, from a financial standpoint, I'm going to be sharing with you some reclasses that we've done just from moving from our old model under our surgeon group to the new model.
Okay.
And that happened on December 10th. So I'm not sure that created some of these downward turns, or if we just had fewer surgeries in December that were scheduled.
Yeah, but I noticed, I went back and looked, we have been haven't been meeting our budget for before that. We have been trending down. Okay, all right.
Some of the surgeons at the evening did sort of.
That impacted it, right, okay.
Before she.
All right, okay, all right.
So on our revenue cycle, again, our days cash on hand for December did come back to about 175. Net AR days fell to 48. And our FTEs per APD for the 3 months is at 5.79 compared to a 5.8 overall. So again, favorable. Our connection enrollment to end the year is going to be at 42,221. Again, that's likely going to fall in January, but we had gotten it right back up to last year's trend. So we'll see where it ends up in January. Hopefully it'll stay close. So for December, the medical center had a favorable month overall, even though we had a difficult budget month for net patient service revenue. Even though admissions were 4% higher, we did have the inpatient ancillary revenue that was lower, which is not necessarily a negative thing, but it does come up as low revenue. We had lower pharmacy, lower respiratory therapy, and so overall inpatient revenue was low, and outpatient revenue was down this month by about 5%. I do also want to mention, although it's not a large number for the medical center statement overall, I want to keep you informed. On the DISH 1115 waiver line item, you'll see a negative $300,000, kind of the third line down in the revenue section. As the state continues to solidify the plan for DSRIP. It appears that we will be moving the measurement period for a large number of our metrics achievement from a calendar year or from a fiscal year to a calendar year. So that is going to limit our achievement period for revenue recognition from the full 12 months ended 9/30 to 9 months, 9/30. So I'm beginning to reduce our accrual for some of those achievement factors. It's not the fact that we don't think we're going to get the same achievement. It's the fact that they have, they're going to be moving the time period in which we can achieve those factors out on a calendar by 3 months. So we're just not going to have the same time frame by the time I have to cut that off at 9/30. So there'll be more to come on that, but I do want to make sure that I don't have a big negative impact at the end of the year. So my overall annual impact is going to be about 1.2 million. So for the next few months, you'll see that line item be a negative $100,000. The salaries this month were over budget from a dollar standpoint of about $821,000, but the FTEs per APD, the flex, was favorable. And also we had another big month of savings in the supplies category. You can see that supplies was under budget by $1.6 million. Very much like November, most of the savings occurred in the lab again, some of our pharmaceutical expenses, and in the medical supply categories. And we had some small savings in utilities and supplies and other operating expenses. So overall, the medical center came in at an operating margin of $1.5 million compared to a budget of $775,000. $687,000 ahead of budget. That brings us year-to-date to a $1.5 million operating margin compared to a budget of $1.8 million. Are there any questions on the medical center?
I've got a quick question. Is the decrease in supplies commensurate with the decrease in the incoming patient? Or are
So
we just getting more efficient?
we're still looking at some of the smaller reasons. One of the bigger reasons in the medical supplies is the downward trend for surgeries. That's where most of those savings, the department that most of those savings is coming from. If you remember back on the volume slides, our surgeries are way under. So I have a feeling as surgeries start to pick up, we're also going to see those come back in line with budget in the later months. There's also some things happening with inpatient utilization for pharmacy, where we are seeing a downward trend in some of the inpatient charging for pharmaceuticals and utilization there, which is a positive thing. And another thing that's happening in pharmacy is there's an overall shortage of IV bags, which you've probably seen on the news. So there's some interesting things that are impacting those, and we're trying to quantify exactly what's happening. Some of those may be permanent, but I think a lot of those are volume driven.
Thank
Okay.
World War II, they ran out of IV. In Vietnam, we ran out of
It's interesting that you have one country that makes the bags, so. Okay, moving on to Acclaim. So the Acclaim encounters remained under budget by about 3% in December, as they were in November. And this is, you don't have this one slide on your iPads or portals, so I wanted to take a minute to talk to you about some of the changes in the way that the new, the surgery budget has changed since the approval process. So the left-hand column, the original budget, represented the way that we had thought about the surgical coverage and the way that it was back in 17. If you look at it, the medical center paid a claim to hire the physicians, and the way that happened is that we contracted with a third party, and we kind of paid them a subsidy to come in and a coverage fee of $7.7 million. And unbeknownst to us, it was completely on their own. They billed and collected from patients, and we paid them this fee to make sure that our patients were taken care of. Through the RFP process that occurred last year, we decided to do kind of a hybrid model, and what occurred is we have employed a large number of surgeons now to take care of our patients, and Acclaim is now billing and collecting for about 17, if I recall, of those providers. So our budget no longer made sense. Now, it's the same bottom line impact at the end of the day, but if you look at the proposed budget that we have in front of you, the main change is we are billing and collecting a lot of patient revenue, and we are also paying a lot of salaries and wages, which was not under the original thought process. So December 11th is when this new contract started, and rather than trying to explain to you every month, beginning in December, all the way through September, that we've got variances in patient revenue and in salaries and wages, I have reclassed within the Acclaim operating budget the new proposed budget. Again, there's no income impact for Acclaim, and there is no changes on the medical center budget for this change. It's just on the Acclaim. We added net patient revenue and we added salaries. Yes, sir.
I just want to mention, Chuck chairs the executive board of Acclaim. This was discussed in full at the meeting this past Monday here. And the question was, again, there's no effect on the overall budget of the district.
Correct.
And Trent, you may recall, we talked about sometimes things get reallocated during the year. And this is one of those cases where it felt like it was best to get the stuff in the right place on the budget. And that's
So
what
should we amend the claim budget?
we thought, since the impact, or at least I think in the discussion, Chuck, correct me, the idea was that since there was no impact to the overall district's budget that it rolls up to, that it would not take, but that's, I'm certainly open if somebody needs to do that. That wasn't a recommendation from the Acclaim Exec Committee.
No, because it was essentially no change. It would just be Sharon
Yeah.
reallocates the numbers.
Yeah, it wasn't an additional $5 million, it was just a reallocation within the budget. So that's, we felt like, but anyway, we want to report that it was discussed fully at the Acclaim Executive Committee on Monday. So, anyway. Thank you, Sharon.
So the Acclaim performance for December, if you start to, if you look at the bottom line, and again, all of the new surgery numbers are included in this, and the employment of the new FTEs are there, as well as the modification of the budget line items that we discussed just now. the operating margin for Acclaim was 1.6 million loss compared to a budget of 1.1 million. And a lot of the reason of that was we did have some GME shortfall on other operating revenue. And if you look up, it's about $146,000 shortfall on the third line item. We will likely have that shortfall for another couple of months. This is an agreement between the medical center and Acclaim, so it is an intercompany agreement. And we are working through discussions right now, number one, to make sure that the correct hours are in the contract and it is the correct rate of payment. So what we're doing currently is accruing to the prior year conservative amount. And what may have happened during the Acclaim budget process, the budget may have been a bit of aggressive on the Acclaim side. So even when the contracts are finalized, we may not make up all of that $140,000 shortfall each month. But I think it's very important that we continue those discussions and make sure not to over accrue on the Acclaim side and that the contracted amount is the correct amount. So more to come on the GME contracts, but I think in the next few months we'll have the final numbers so that we can kind of finalize that. Some other drivers of the budget shortfall this month was the decrease in volume you can see that net patient service revenue was down by about $534,000. Salaries were down, but they were not down as much as you would expect because they did have an overage in some of their call pay for coverage with some increased holiday time off. And there was some legal invoices that were paid that created a bit of an overage in purchase service, along with a small overage in supplies. But if you look over at the year to date, they were at 3.6 million compared to a 3.9 million budgeted operating loss. So year to date, Acclaim is right on budget. They're actually slightly ahead of their operating budget for the first 3 months of the year. Are there any questions on Acclaim? I've been up here a long time and I've covered 2 months.
You are agenda item number 1.
It is my committee, right? Okay. Okay,
Point well made.
all right. Yeah.
Point
So,
Clark.
This is what it's all about. And it's a good month. I want to take it in while I can. All right.
Clark 1, early 0.
Yes. Well, that is my sign to exit stage left, so there are no other questions.
All right, any other questions for Sharon? We'll have to take these separately, so I'll entertain a motion to accept Ms. Clark's report on the November financial report. We have a motion by Mr. Powell, second by Mr. Nguyen. All in favor, please say aye. Aye. Opposed, motion passes. Consider a motion on item B, acceptance of the December financials. Motion by Mr. Nguyen, second by Dr. Weber. All in favor, please say aye. Aye. Opposed, motion passes. Thank you, Ms. Clark.
Thank you.
The next 15 items, council has a little statement he'd like to make.
Yeah, Mr. Chairman, members of the board, your vote on these next items on policies will be a board vote, not a recommendation from this committee, and that'll be reflected in these minutes since this is a joint board meeting, posted as a joint board meeting and finance meeting. All of these policies are on the 3-year cycle update. that is required by the Joint Commission. There is one policy that is new, that is item H, and Dr. Schrader's here if you have any questions about that one modification, that one new policy. Otherwise, the modifications to all these policies are primarily non-substantive. They're formatting back. They're a couple of years ago. My office and Scott Rule's office and Ron Skillen's office talked about consistent formatting of policies. So that's some updates. Some of these had not been updated since that had been implemented. So you do have to take, Mr. Chairman, unfortunately, each one of these separately. So you're on item C.
So we have a room full of subject matter experts, and we'll spend as much time on any of these that anybody wants. So I don't want you to feel like I'm rushing through these, but I do want to get through them. So what I'd like to do is just take one by one. If there's a question, we'll call up the subject matter expert to discuss the question. Otherwise, I'd like to just hammer through these. We've all had time to review them. They were in our board book. So
In addition to the policies, you had posted also red line of the policies, but also red line of the procedures that go hand in hand. You're not approving the procedures. They're there for your information only, but the policies are there for approval. So
correct. Okay. So item C, any questions on item C on the policy regarding subpoenas involving patients, employees, visitors policy?
Move for approval.
Motion by Mr. Powell, second by Mr. Bose. Any further questions? All in favor, please say aye. Aye. Opposed, motion passes. Item D, consider approval of the marketing practices policy.
Move approval.
Motion by Mr. Bose. Second by Reverend Emerson. Any questions regarding this policy? All in favor of the motion, please say aye. Aye. Opposed, motion passes. Item E, consider approval of acquisition, disposal, and leasing of real property policy. Motion by Reverend Emerson, second by Dr. Weber. Any questions on this policy? All in favor, please say aye. Aye. Opposed, motion passes. Item F, consider approval of the safe medication practices policy.
Move approval of the safe medication practice policy.
Second.
Motion by Mr. Bose, second by Mr. Powell. Any questions on this policy? All in favor of the motion, please say aye. Aye. Opposed, motion passes. Item G, consider approval of the Texas Vaccine for Children Program policy. Motion by Mr. Nguyen, second by Mr. Bose. Any questions on this policy? All in favor, please say aye. Aye. Opposed, motion passes. Item H, consider approval of medical staff drug and alcohol-free workplace policy. Motion by Mr. Nguyen, a second by Reverend Emerson. Any questions on this policy? All in favor of the motion, please say aye. Aye. Opposed? Motion passes. Item I, consider approval of the critical values policy. Motion by Reverend Emerson, second by Mr. Powell. Any questions on this policy? All in favor of the motion, please say aye. Aye. Opposed? Motion passes. Item J, consider approval of the fall prevention program policy. Entertain a motion.
But I had one comment, if I may.
Yes, sir.
This is a multiple disciplinary function, the falls. And what I asked Chet was, it said the policy affects all medical staff, RNs, graduate nurses, but it doesn't, it also specifically talks about LVNs. It does not address physician assistants. And my question to Chet was, are physician assistants considered part of the medical staff?
For credentialing purposes, they are. They do come under that, they are under the same credentialing peer reviews.
What I'd recommended to Dr. Weber is that maybe we could be more intentional and use credentialed practitioner as the scope of medical staff, especially in the oversight of quality, is expanding into allied health and other licensed professionals. I think we'd just be more intentional with the verbiage.
Okay, so we'd like to amend the policy?
Yeah. So you're considering the policy in the amended form as proposed by Dr. Schrader, and I'll clean that up for
Reflect that.
I'll have to reflect that. Okay.
So we have a motion, would entertain a motion to approve this policy with Dr. Schrader's modifications.
Approval as amended.
There's a motion by Mr. Powell, second by Mr. Petty.
Mr. Chairman, it may be wise at this point to let some of you know that Dr. Schrader is the current president of the medical staff. And we are delighted to have him here, and we are delighted for his contributions. But I know that when Dr. Schrader began to make that motion, a couple of y'all looked up and said, we're happy to have him on the committee, which we are. But that's his role as the president of medical staff, and you can see what a wise choice that is. And thank you for that addition.
No question.
He's here in his capacity as a member of the board.
That's right.
Awesome.
In that capacity.
We like the amended version, it more broad range. Good point, Chuck.
We have a motion and a second. Any further questions on this policy? All in favor of the motion, please say aye. Aye. Opposed? Motion passes. Item K, consider approval of the moderate sedation policy. Sometimes I need that. Entertain a motion. Moderate is the operative word there. I'll entertain a motion on this policy. Motion by Mr. Bose, second by Reverend Emerson. Any questions on this policy? All in favor of the motion, please say aye. Aye. Opposed? Motion passes. Item L, consider approval of the restraint and seclusion policy.
Another one.
I need that one too.
We're on a roll here,
We
so
are.
another one.
It's all about me, isn't it? I entertain motion by Mr. Bose.
Your wife's here.
We have a motion for approval, a second. Entertain a second. We have a second by Reverend Emerson. Any questions on this policy? All in favor of the motion, please say aye. Aye. Opposed? Motion passes. Consider approval of the hospital-wide recovery policy. Entertain a motion. Motion by Reverend Emerson.
Second.
Second by Dr. Weber. Any questions on this policy? All in favor of the motion, please say aye. Aye. Opposed? Motion passes. Item N, consider approval of the point-of-care laboratory testing. Entertain a motion for approval.
So moved.
Motion by Dr. Weber, second by Ms. DeBose. Any questions regarding this policy? All in favor of the motion, please say aye. Aye. Opposed? Motion passes. Item O, consider approval of the organ tissue and eye donation policy. Entertain a motion. Motion to approve by Reverend Emerson, second by Ms. DeBose. Any questions on the policy? All in favor, please say aye. Aye. Opposed? Motion passes. Item P, consider approval of the Sentinel event policy. Entertain a motion. Motion by Ms. DeBose, second by Dr. Weber. Any questions regarding the policy? All in favor of the motion, please say aye. Aye. Opposed?
The next item is an archival, as you're not actually approving, sir.
I knew that.
Item Q, okay.
Do we have to approve? We don't have to approve it?
No, you have to prove it. You have to prove the fact you're archiving. I wanted to point out it's a little bit different what you've been doing, so.
Oh, okay. So, archival of the event reporting policy. I guess that means like we're throwing it away or something.
That we're putting it to bed.
Put it in a very safe place. Entertain a motion for approval of this archival. Motion by Reverend Emerson. Second by Ms. DeBose. Any questions regarding this archival? All in favor, please say aye. Aye. Opposed? Motion passes.
Mr. Chairman, I want to thank you. I want to thank you because you know this is a joint meeting, and as finance chair, you've done an excellent job. Also, as former chairman, this was not something I didn't put on here. The first actual board meeting is the 8th of February, so it's just coincidental that this being the first meeting. We appreciate getting on this agenda. So
you suckered me
don't
into
say a
that.
word, Robert, about where we put
No,
this.
I just want to thank staff because we have so many items on finance today. We went to a Greek alphabet.
Yeah.
We've gone past our normal.
Yes.
And gone on, so thank
My
staff for their
learned
innovativeness.
colleague up there probably think that we push it on his agenda. This is the first official opportunity.
Exactly.
You suckered me into this.
Anyway,
Yeah.
thank you.
We're going to table item R for the time being and move to item S. Consider approval of product purchase agreement between Olympus America and Tarrant County Hospital District. Ms. Peebles. Hi, Wanda.
Good morning.
Good morning.
I'm coming before you this morning to ask for approval for Olympus Endoscopes. This is the second part of a program that we've put in place. Last fiscal year, we purchased the high-definition imaging equipment for our endoscopy department. This year, we're asking to go back now and exchange all of our current endoscopes to meet that high-definition resolution to marry up with that imaging equipment. So what we would be doing is exchanging out all of our current endoscopes for the new high-definition resolution scopes. These scopes take us from a 480 pixel resolution to a 1080 pixel resolution, which gives the physician much more clarity when they're doing these procedures. So I know it's a large amount of money, however, that does encompass 49 different types of scopes, colonoscopes, gastroscopes, bronchoscopes, ERCP scopes. So this will be for our main endoscopy department here at the hospital.
Any questions for Wanda on this item? Motion by Mr. Petty, second by Mr. Bose for approval. All in favor, please say aye. Aye. Opposed? Motion passes. Thank you, Wanda.
Thank you.
Item T, Melinda.
Good morning.
Good morning.
It is still morning, that's good news. I'm here to talk to you about the product called ChartMax. ChartMax is the place where we store all of our documents that are not electronic. So you can imagine I don't like them already. But we do have a lot of paper documents. We have things like driver's license that people come in, that's what we use for identification, so we scan that. We have some EKGs that physicians will do an EKG and then write a note on the strip itself. So then we have to scan that strip to make sure that we have all that information in the electronic medical record. And then often patients will come in with documentation from other hospitals. We want to make sure that we have that as well because that might determine what our treatment might be. So all those things are scanned into our product called ChartMax. ChartMax has ended its term here for our current contract, and so we want to renew that contract. We knew that was coming up. We did budget for it, as you can see in this document. So we'd like to have approval for continuation of the use of this product. Also, the new release is compatible with our new Epic release that we're going to be implementing in April, so it's a secondary reason that we really need to get it in place right now. Any questions?
You've heard the question, heard the description from Melinda. Any questions? We have actually two motions, pardon me, Reverend Emerson, two motions. One is to exemption to bid.
Right.
And on the basis of practicality, and then actually the approval of the request itself.
mentioning
It could be one motion, but it has two elements.
Oh, two elements.
You're
All right.
approving exception to the bid statute and approving the contract.
Okay. Is that acceptable? Okay. Reverend, motion by Reverend Emerson, second by Dr. Weber.
Does this interface back into that Healthy Planet and all that stuff for the care manager to use?
It will, but Healthy Planet doesn't allow for the non-electronic documents, so this does support Healthy Planet in that regard.
What is that?
Go ahead and hit your mic, DT.
I was just wondering if it's going to be interfaced with the Healthy Planet, which is the care manager for Epic, for the care manager to
Kind of
access.
a new feature in Epic to help us manage our population better.
Interesting. Okay. We have a motion and a second. All in favor of the motion, please say aye. Opposed? Motion passes. Thank you, Melinda.
Thank you.
Mr. Mendenhall. Item U.
Thank you. Chuck came back and needed some IT support when Melinda was coming up here, and I knew Melinda would be up here at least 10 to 15 minutes, so I was comfortable doing that. In front of you is a proposal to expand our data center services. We currently have two data centers, one here at the hospital, the second one that we contract out to SunGard Availability Systems in Richardson, Texas. SunGard is where we host Epic for the most part, and actually most of our applications are hosted out of that data center. Over the last 5 years, we've been kind of month to month, year to year with SunGard, and as we've been working with Steve and trying to put together what our long-term data center strategy needs to be for JPS, we realized that getting rid of SunGuard right now would be a very difficult thing to do. And so to unravel that relationship with them and what they do for us. So we went back to SunGuard and asked them to put together a longer term, a 3-year plan for us, a 3-year term. And by doing that, we were able to save about $200,000 a year, which is significant because now as we start looking to go to hosted services like in the cloud through Azure and through Amazon Web Services, now we have some monies to be able to start building out that platform over the next couple of years.
You've heard the description from David. Any questions? Ah, okay.
And again, you're considering this as an exception to bid as well as approval of the contract.
Correct. Entertain a motion.
So moved.
Second.
Motion by Dr. Weber, second by Mr. Nguyen, with those caveats of the exception to bid. All in favor of the motion, please say aye. Opposed? Motion passes. Thank you, David.
Thanks.
Ms. Walker, item V. Morning.
Good morning, everyone.
Good morning.
This morning, I would like to present to you 3 staffing contracts as well as our press Ganey contract. As stated before, when we presented 3 of the 6 contracts, when we do put contracts out, our first rim for business with any type of recruitment is to utilize our in-house resources, which is our talent management team. But we do like to have contracts on hand in case there are unique situations that we would need to recruit for. So I would like to go through these 3 contracts to ask you for your approval this morning.
Sorry, yeah, that's VW and X?
Yes, sir.
So we do have to do these separately?
Yes.
Yeah.
Yes, okay. So the first contract is Aya Healthcare.
Motion by Mr. Bose. Second by Dr. Weber. Any further questions for Pia? All in favor, please say aye. Aye. Opposed, motion passes.
Okay.
All right.
The next one is Cross Country Healthcare.
Motion by Mr. Petty, second by Mr. Bose. Any further questions for Pia? All in favor, please say aye. Aye. Opposed, motion passes.
And the third one is Maxim Healthcare.
Motion by Mr. Bose, second by Mr. Powell. Any questions for Pia? All in favor, please say aye. Opposed, motion passes. And item Y.
Yes. The next contract is for Press Ganey. Press Ganey is our vendor that we utilize to do our annual employee engagement and physician engagement survey each year. Of course, for the previous year, it was $97,000. There is an increase in the contract because we did include this year with us the physician engagement survey. So this morning, I ask you for your approval for this contract.
Why don't you do this in 1 year basis? They just, do they not offer a longer term?
No, they usually do it on a 1-year basis for us, yes. In the past, we have been with them for the last 5 years, and it's always been a 1-year contract, yes.
Thank you for Pia's description. Any questions? Entertain a motion.
So moved.
Motion by Dr. Weber, second by Reverend Emerson. All in favor, please say aye. Opposed? Yes, sir. And one, all in favor, please say aye. I think we just did that, and one abstention.
Mr. Nguyen. Mr. Nguyen will be abstaining.
Okay.
Thank you.
Thank you.
Okay.
No, yeah, that's no problem.
Why did he abstain?
He knows the CEO.
Oh, okay.
Your mic is on.
No, it's not. It's, all right, it's green. Hello, 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 hello. Item Z, Kathleen, good morning.
Hi, good morning. I'm here with 4 contracts today for consideration, and the first one is with Steris Instrument Management Service. This is the first amendment to a contract that was originally with IMS, or Instrument Management Service, which was purchased by Steris and now owned by that. The contract originally was RFP'd, and this is the first amendment that will allow us to continue to the repair of surgical instruments. That includes the power tools for ortho, scope repairs for the scopes that Wanda was just handling, and saw sharpening also for the OR. And this is a $256,000 contract, and it's a 3-year agreement. $256 per year.
Yes.
You don't want dull salts in your mind.
You
We
don't
don't.
want dull salt.
No. I'd say we have a dull CEO, but I won't say that. Yeah. Okay. We have a motion by Mr. Petty, second by Mr. Bose. Any further questions for Kathleen? All in favor of the motion, please say aye. Aye. Opposed? Motion passes. Thank you. Item AA.
The next contract is with Siemens Healthcare, and this is for the disposable reagents used on our Vista analyzer, which is for our routine chemistry testing that is done throughout the hospital. This did go through an RFP process and had 4 responses, and it covers about 650,000 procedures a year. It is a $1.1 million annual contract, and it is a 5-year term.
Okay. You've heard the description. Any questions for Kathleen? Entertain a motion for approval. Motion by Dr. Weber, second by Reverend Emerson. All in favor, please say aye. Aye. Opposed? Motion passes. Item BB.
This is a second amendment for ARUP Laboratories. ARUP is our primary reference lab where we send specimens out for tests that are not routinely done here at JPS. This originally did go through a value analysis and RFP process. It does cover at least another 280,000 procedures a year. What we're doing is consolidating all of our reference work into 1 or 2 laboratories so that we can get an improved price per unit decrease. This will also allow us to drop one of the current reference labs, and that test alone will bring in an additional 16,000 volume. And on a unit cost, it'll reduce the cost from $14 per unit to $10 per unit for the additional 16,000. So this is a $6.6 million annual cost, and it is for an additional 2 term. It is for a total cost for a 2-year term.
Total cost 2-year term, okay. You've heard the description. Any questions for Kathleen? Motion to approve by Reverend Emerson. Second by Mr. Bose. All in favor, please say aye. Opposed? Motion passes. Item CC.
The last contract is with Sysmex, and this again is for the lab, and this is a leasing contract for a new analyzer for hematology services. It also includes the reagents and the service on that analyzer. This did go out for RFP, and it did have 3 responses, and it is comparable to previous costs that we incurred for doing the same procedures. This is a $333,000 annual cost, and it is a 5-year term.
Any questions for Kathleen?
Move for approval.
Motion by Mr. Powell, second by Reverend Emerson. All in favor, please say aye. Aye. Opposed? Motion passes. Thank you, Kathleen.
Thank you.
6, Mr. Adams, any reports from legal?
No, one is a amendment to Part 4 of the medical staff bylaws.
Sorry about that. An amendment to the Part 4 of the medical staff bylaws. All this does is consolidate 2 departments. The Department of Community Medicine will and Family Medicine will now be the one department, Family and Community Medicine. I believe that's the only thing, Dr. Schrader, correct?
Correct.
Okay.
I'd move for approval.
Motion by Mr. Powell, second by Dr. Weber. Any further questions for council? All in favor of the motion, please say aye. Aye. Opposed? Motion passes. Anything on item B?
Yeah, the second item is a consideration of an amendment to policy LD 2200, authority of chief executive officer to make contracts and to settle claims and lawsuits. The current threshold is that anything 200,000 or above has to come to the board. The proposed amendment would change that threshold to 500,000, that anything 500,000 above would have to come to the board.
Got it.
So what's the purpose for this?
This was discussion. Go ahead.
Yeah, actually, it's something I had suggested. Back when Robert, prior to Robert, his predecessor, the limit was 500,000. And when Robert became the CEO, he had asked us to move it down to 200,000, and we did. Just looking at a lot of the contracts that are coming through, I suggested that we look at taking it back up to where it was before, to 500. Robert has been somewhat resistant to it, but it's probably based on my laziness because I'm tired of looking at all these contracts. I'm kidding. Just the idea that that was our prior policy. I think we can trust Robert now, and I thought, let's take it back up.
Yeah, I don't disagree with that at all. I guess my question is, to me, there's two very, very separate issues here. There is the normal approval of budgeted monies through a contract that goes $500,000, but
Right.
then there's the settlement issue, which to me is a different can of fish.
It is.
Okay, they are two different things.
Yeah.
For my purposes, I would still prefer that settlement issues come back to the Finance Committee for recommendation and board for approval at the previous level, only because, A, I don't want to put that much responsibility on him for settling what could be a divisive lawsuit. And secondly,
Settlements are just lawsuits?
Yeah.
Is that?
Yeah.
Okay.
Those are two separate concepts.
Over just a little bit.
Yeah, those are two separate concepts under the policy. You have one, the threshold for contracts, a separate one for settlement of lawsuits.
So can we
You can, yeah,
then
absolutely.
establish the
You could have a
limit?
different threshold for both.
Just
I think-
separate them out.
I think it's a very good idea.
My recommendation would be 200,000 remain on the settlement
I
component.
completely agree. I think that's a very good idea.
Well,
So that,
200
is that
on-
material to this?
Yeah, we'll need to, Trent can make a amendment to the proposed modification of the policy to reflect that the threshold going from 2 to 500 would only be as to contracts, and the policy would remain the same at 200,000 for settlement of lawsuits.
Okay.
Yeah.
Which I agree with.
Okay,
100%.
I think it helps you.
I
Do too.
agree.
One thing I might, Mr. Chairman, Sharon Clark's office did a survey, and or went back and looked at the contract last year. She and my office did, and we did 175 contracts that were last year that were above 200,000. Of that 175, 57 would have been in this 200 to 500 range. So it takes about a third of the contracts off as far as coming to the board. Okay.
And back to the question of Robert, those contracts are still reviewed.
Oh,
They'll
yeah,
still come
say
through my office.
Full legal review,
Yeah, they
nothing
still come-
changes there.
yeah,
And
they
he
still
can
come
still
through
bring
my-
whatever he wants. to
That's
the full
correct.
board,
He has the
right.
right to still bring
Yeah,
something if he
yeah.
wants to elect.
Yeah, I mean, if Robert and his staff says, hey, this is something I want the board to consider, he always has that option.
Obviously, they're two different separate things.
Yes, sir.
I agree with what Trent's saying.
As we move that, I would still like to be able to make sure that on our spend and diversity, that is still reported to us, and how we're doing on that.
that
I
won't
don't want
change.
to
Yeah, and we'll still
move
put 'em
that
on the
without-
portal.
Those contracts, just like the ones we do right now under 200,000, are posted on, you're alerted, they're posted on your board portal, and we'll do the same thing. This will just add these contracts to that list.
Yes.
Okay.
Yeah, they may be posted, but I still want the review of the spend, and that still be reported up. And we do that through the diversity and inclusion.
Yes, ma'am, and
so,
that will
yeah.
not change.
Okay. Yeah. Okay, I still just make sure it's there.
And this will fall under the normal yearly audit from BKD and everything else, right?
Oh, yeah, this doesn't
Doesn't
impact
change
the audit
any
at all.
Any of that.
Side of those.
No, sir. They'll still be there.
Okay, good questions, good improvements. So, do we have a motion as modified?
It's not turning green. I'm one of our Chet's, his works. So I'm going to make a motion that the policy amendment remain at $200,000 for settlement of claims and lawsuit, and that the policy be amended to $500,000 for contract approval.
This is a recommendation of the full board, so.
Yes.
And we'll,
Finance committee recommendation
right, there's a
and not
finance
a
committee
board.
recommendation, full board, and we'll make that modification and when we submit for the board approval, okay?
All right, we've heard the motion. Second by Mr. Bose. Any further questions?
Well,
Yes, sir.
this item goes to the full board, will it go to the full board at the consent agenda or another item that we vote on?
It would,
do it either
it would
way.
typically be a consent agenda. Obviously, it's something somebody could pull off. Okay.
All in favor of the motion, please say aye. Aye. Opposed? Motion passes.
Just point of reference, when Steve brought this up, I felt like it's a finance issue since contracts are reviewed here. That's why I came to finance. But it can certainly be pulled off if somebody wants to discuss it.
Okay, we will recess and reconvene in closed session. Yes,
Mr. Chairman, can I just say one thing? I know sometimes we lose staff in between this going to close. I just want to say thank you, and I've expressed this to Robert, to please express to the staff you know, with everything else we do in this hospital, we do a tremendous job. But please, to the individuals in this room and to your staffs that you work with the flu epidemic, I think the JPS has stood out to do a phenomenal job. And on behalf of the board, I think I get the honor to represent the board. I just want to say thank you while they're here, because I know some of them may not come back after closed session, so thank you.
Thank you, Mr.
Good deal. Good deal.
All right, the Finance Committee will come back to order. Counselor?
This, as I want to mention, I mentioned earlier to the board, when we looked at this in executive session on appointments and reappointments, this month was a little bit different since we didn't have a board meeting. So under the Joint Commission rules, 2 officers can approve the appointments and reappointments in the interim, which Charlie Powell and Chuck Weber both did as the chair and vice chair. So you're being asked to ratify the acts of Charlie Powell as chairman of the board and Chuck Weber as vice chairman of the board, approving the appointments and reappointments, ratifying their act of approving the appointments and reappointments of 151 medical and advanced practice professional staff.
A motion by Mr. Petty, a second by Reverend Emerson. Any questions of council? All in favor, please say aye. Aye. Opposed? Motion passes. Being no further business, we're adjourned.